invitation to talk. Chris has asked me to talk about the national network. So as much as I love Northland DHB and Northland District in particular, and would happily retire here, another rest of the country to go through. So I'll give a very brief overview of it. I won't dwell on the areas that have already been covered. This is the national network, 4 regional groups, of which ours is the Northern region, but networks through the Midland, Central and the whole of the South Island. It's a tale of two halves. The Northern region and the Midland region networks have been established for a reasonable period of time. They function very differently, but the key feature of them is a good level of regional collaboration between the various between the hospitals and DHBs in them. The Central region, the South Island region, really only started in mid-2015 at the prompting of the Ministry of Health guidance for DHBs and for regions in the annual planning. That gave us, it's not a particularly heavy mandate, not like, for example, what the state of Victoria have, which is a legislative mandate to implement trauma. Ours is lighter, but it is still quite effective, and to date we have got, we've got trauma, the networks functioning in all 4 regions now. At a national level we're funded just under $500,000 a year. About half of that is contributed by DHBs for the funding of the registry that's hosted currently by Waikato DHB, and the rest of it is other program costs, and that includes Ensemble, who's been up here before, who's the national lead, and various other, my role and various other roles that we have. We've got 3 priorities, and we're just at the stage now that we've achieved most of these priorities. So the first one is to implement a formal trauma structure. We've achieved most of the things that we set out to do in this. I think the last one on this, and the one that's probably the most encouraging for us, is the plethora of education events and symposiums that are happening around the country in trauma, such as what's happening here. I think they're fantastic initiatives to really build up that grassroots interest in trauma. Cross-sector relationships we are building on, and that's going across various other agencies. So for example, New Zealand Transport Agency, which is funding a RACS, the Royal Australasian College of Surgeons, later this year will be undertaking a system review of the New Zealand trauma system, which is what we have, NZTA funded, where we've initiated that, and that's really just have an external expert review of how we operate as a whole of system. The second priority, I think, has been dealt on a fair amount, so I won't go over that. And the third area is the key initiatives that we've achieved in there is the out-of-hospital destination policies, which is taking patients to designated hospitals first time, a new triage tool that ambulance officers use, and staging guidelines. And they've been implemented since end of March this year, and we'll be reviewing that, undertaking an audit of that later on this year. While we have achieved most of what we set out to do in the initial 3-year planning period, there are still some squeaky wheels. The South Island in particular is still, we're still really struggling with resourcing there and having sufficient resources to collect the data. We don't have a particularly good ability at the moment to address the gaps in the health system. The data that we've got is still very new data. We don't have the number of it's quite limited. We are expecting about 2,000 cases a year through the registry, so it's going to take us a fairly long number of years to build up sufficient data to really inform quality improvement initiatives. Rehabilitation, I think, is a significant aspect that we don't really fully understand. We don't have a national view of. We don't have particularly good view of what good rehabilitation for most trauma patients. There's a reasonable understanding around TBI and spinal, but for the rest of trauma patients, we don't have a good view of what good rehabilitation looks like. So the next part of this is, where do we go from here? The initial focus has been on setting up the real foundation work. We've achieved most of those things, and now it's where do we go to from here. This planet, we're just in the process of drafting up a long-term strategic plan for the national network. This is very much in draft form and needs to be taken as in draft. But it encompasses 4 areas. The 3 at the top are really the core bits that are going to make a difference to patients and a difference to hopefully to how you work as well. The first area is service excellence, and that's articulating what does good trauma look like, both in terms of prevention, hospital care, rehabilitation, and returning people to as good a function as that they can get back to. We know reasonable parts of this, and to date our focus has been really on the pre-hospital, hospital aspects, and over the next 5 years I think we need to start looking more into the prevention and rehabilitation aspects. The enablers to enable this to happen, which is around the technology and particularly the registry, and how we can ensure that we utilise the best technology that we can have. For example, we're looking at auto-population of the ambulance EPRF data into the registry to reduce the administrative burden on the trauma data collectors. The workforce, what does the workforce need to look like? What are our gaps in the workforce? What do we need to do to correct those gaps? And then have we got the right structures and facilities in place? The big area here, actually I'll come back onto the Trauma Research Alliance in the next slide, and then at the bottom we've got the system governance, which is really continuing to do more of what we've done. To date we've focused a lot on that area. As we go forward I think that goes into a maintenance mode and it ticks over. The Trauma Research Alliance, we've heard a lot about data, and the information and the data that we're collecting and how we're collecting it and where it goes. But at the end of the day it is just data. I think it was a fantastic presentation about the cost, and I think we really want to see and build up a structure now to transform that data into useful information to then come back and inform those quality improvement initiatives. And again, this is very much in draft form. This is a sort of an aspirational wish list, if you like. But broadly, what we've got at the moment is very limited analytical function. Where we want to go in the future is looking broadly at 3 different levels. The first is DHB and regional facing, so that we support regions to analyse their own data. And that's through continuing with a single web-based registry, but also introducing some business intelligence tools to enable people to interrogate and slice and dice their own data. And translational research, so that's very much grassroots research in terms of how can you identify, based on your day-to-day work, where the problems are and what you can do to fix those problems. National level, so using the data that we've got to drive both aggregate reporting at a national level, performance measures, how do we compare, how do our mortality rates, have we got, are we transferring our levers, or for example in the pre-hospital space, have we set that at the right level to make sure that as many patients as possible get from the scene to the hospital for definitive care first time. Focus area research, I'd like to see more research particularly on Māori and cost, but also looking across databases, for example, so that we can have a view of patient information in the particularly around road traffic crash related information, which is about 50% of the national workload, national caseload, to look at that with our data, with the rehabilitation data, and to be able to pull up some really informative information around that to both inform how well we're doing, but also very much to inform those injury prevention measures. Long-term outcomes, there was a study just recently finished at the AUT, the Auckland University of Technology, around a pilot study around long-term outcomes for trauma patients, and that looked at patients, I think it was 6 months and 12 months post-discharge from acute settings to see how well they coped post-rehabilitation and what their quality of life is. So we're just waiting for the formal results for them to come through. And the third area is to support that academic research. That's that deep, I think we've got a real opportunity in New Zealand with a relatively small population and a great level of collaboration between various agencies and partners at a government level, but also through the network, through the regional levels as well. So we're working on a long-term strategic plan at the moment and various business cases around this. So we're not there yet, but we've certainly got lots of ideas of where we want to develop the national network and where we're going. So thank you.
I've got a quick question, Siobhan, with regards to Northland and Whangarei. Can you just tell us a little bit about the major trauma destination policy and where that's at with its rollout and how you think it might affect us? Is that possible? Can you do that in a minute?
Sure, yes. Yeah, absolutely. Okay. Well, it's rolled out. It was implemented nationally at the end of March. I think the key changes for Northland DHB, there are a couple. One was the use of staging hospitals. So, for example, if somebody had a road crash near to Kataia Hospital, for example, and they were severely injured, the ambulance crew would have the option to take that patient to Kataia Hospital for staging. The air transport would be, I'm a little bit embarrassed because I know that you're here, but the air transport would be tasked by the ambulance officers at the scene, and literally they would be taken to Kataia Hospital to wait until the ambulance arrived. Kataia Hospital would provide as much care as they could, and it's a real balance between the capability at the staging hospital, the time of transport and the condition of the patient. So, and then that patient would be taken either to Whangarei, depending on the injuries, or directly down to Auckland. So that's quite a new concept in New Zealand. It's been used a few times nationally. I don't think it's been, I'm not sure, Scott, you'd probably have a better view that if it's been used in Northland yet.
I'm not sure.
I haven't heard of any up here. No.
Only a spinal bypass.
Sure.
That's outside the staging concept. That's a bypass concept.
But I wouldn't. And the other change I think for Northland was particularly around the paediatrics, that more paediatrics would overfly directly to Starship, particularly if they came from outside of Whangarei. And the other bit was patients who were significantly south of Whangarei, where feasible, those patients would be taken south rather than north. So is that, Scott, have I missed anything on that? Or?
No, that's right.
Yeah.
So we'll probably see that 21% of patients transferred in the first 72 hours come down because of more people overflying Whangarei.
Yeah, I think that was a national aggregate. The northern region was about 22%, 23%, so definitely I think it would be good to see that come down. I don't know if there's a magic number that we want to achieve, but certainly 1 in 5, 1 in 4 seems a little bit too high.
So the concept of staging was around that there's frequently significant delays when you get tied up in rural hospitals, so it's an enabler to basically get the helicopter in there quick and the patient out faster to the correct destination, the most appropriate destination.
I think The other thing actually, just on it, for Northland DHB specifically, is around the 0800 for trauma number, which I know, Scott, you've promulgated that very widely with your teams. And you know, there has been a few squeaky wheels around it, but I would hope that that's a, I don't know if everyone's aware, but it's a number if you've got a patient to be transferred to Auckland City Hospital. It's a number. It goes directly through to the intensivist on call, who can organise that transfer. So, and it actually, the impetus for that really came out of Kantaya Hospital, where I think somebody went back, tried to transfer a patient and went back onto the telephone logs, and I think there's something like 38 phone calls in and out for a sole doctor working on their own, trying to organise the transfer.
So now it's just one phone call, 0800 trauma,
yep.
and that's it, which I think is a fantastic thing.